Welcome to the Deep Dive. Today we're tackling something that's, well, probably on the mind of anyone managing patients with venous thromboembolism, or VTE. We're talking about the treatment itself, anticoagulation, and its most feared complication: major bleeding.
It's a fear that's absolutely grounded in reality. We're not talking about minor issues here. These are serious, potentially life-threatening bleeds. The numbers themselves are quite sobering. Depending on the specific anticoagulant you're using, major bleeding can happen up to, say, 7.22 times per 100 patient years.
Wow, that's significant.
It is. And when a major bleed does occur, the case fatality rate is around 9%.
Nearly 1 in 10.
Exactly. A nearly 1 in 10 chance it could be fatal. And what makes it even trickier is that the risk isn't flat over time. It's actually much higher. It really peaks in those first few months right after starting treatment.
Okay, so that initial period is especially dangerous. So our goal in this deep dive is to give you a really practical framework for navigating this bleeding risk throughout the entire treatment journey. This isn't just about, plugging numbers into a calculator once. The sources we're drawing on describe a dynamic sort of longitudinal approach. It blends good old clinical common sense, proactively going after risk factors you can actually change, and using validated scoring systems strategically.
That's a perfect summary. It's a process, not a single event. And maybe before we jump into the stages, it's helpful to frame why we're doing this risk assessment in the first place. There are really 4 key goals when we assess bleeding risk in VTE.
Okay, what are they?
First, and maybe the most obvious, is identifying factors we can actually modify. Things we can intervene on to lower the patient's overall risk right from the get-go.
Right, the preventable stuff. Makes sense.
Second, it helps us choose the best class of anticoagulant. Is this patient better suited for a newer DOAC, or do we need to stick with an older agent like warfarin?
That drug choice is huge, obviously.
It is. Third, the risk assessment guides the dose. Sometimes we need to adjust the dose down based on specific patient factors or potential interactions.
Dose optimization, got it.
And fourth, and this often comes up later, it helps determine the optimal duration of treatment. This is especially critical for those patients considering staying on anticoagulants indefinitely.
Okay, those 4 points: reducing overall risk, picking the drug class, setting the dose, and deciding on duration, that really lays out the roadmap. So let's unpack this, starting right at the beginning. Stage 1, that critical moment of diagnosis.
Yeah, we can think about managing this risk across 4 key time points, 4 stages. Stage 1 is right at diagnosis, when treatment starts. Stage 2 is often around hospital discharge. Stage 3 is typically at the 3-month follow-up mark. And stage 4 is the long-term follow-up for those on extended therapy.
Makes sense. So focusing on stage 1, at diagnosis initiation, the priority here is getting the anticoagulant started, right? Usually for at least 3 months.
That's the standard. For any new VTE, therapeutic anticoagulation for a minimum of 3 months is typically mandatory.
So given that urgency, what's the main goal regarding bleeding risk right then and there? And how do we avoid causing immediate harm?
The goal is really minimizing risk during that mandatory initial phase. Look, in almost all cases, the need to prevent another clot, especially a fatal PE, it just outweighs the immediate bleeding risk.
Almost always.
Almost always. But there are definite hard stops. We absolutely have to identify situations where starting anticoagulation would be, catastrophic, absolute contraindications.
Okay, so what are those absolute non-negotiable situations? Where do we absolutely have to hold off?
These are the times when stopping bleeding is the #1 priority, even over treating the clot itself. We're talking active intracranial bleeding that's often immediately life-threatening,
Right.
or any other ongoing major bleed that poses an immediate threat to life. Also, right after certain major surgeries where there's a very high risk of bleeding at the surgical site or into an organ, we have to wait.
Makes sense. What about blood counts?
And the final one is critical thrombocytopenia. So really low platelet counts, generally below 30 times 10 to the 9th per liter. In all these situations, the sources are clear. You have to withhold therapeutic anticoagulation until that immediate bleeding risk is controlled or the platelet count improves. It often takes a whole team approach, very close monitoring.
That sounds like an incredibly tough spot to be in. You hold treatment, you risk another VTE, you risk a potentially fatal bleed right now. How do you make that call?
It's about tackling the most immediate threat to life first. While the VTE is definitely dangerous long-term, an active brain bleed or a massive post-op hemorrhage can kill the patient right now or cause devastating disability.
So immediate survival trumps the clot risk in those specific cases.
Exactly. You stabilize the bleed first, then you reassess starting the VTE treatment.
Okay, so if you do have an acute VTE, but one of these absolute contraindications, what can you do in the meantime? How do you buy time?
Good question. If someone has a big DVT or PE but just can't get anticoagulation yet, we have some temporary measures. One common strategy is placing a retrievable vena cava filter that can help catch clots traveling up from the legs towards the lungs.
Like a safety net?
Kind of, yeah. If the issue is severe low platelets, then repeated platelet transfusions might be necessary to get the count up. And in some very specific, carefully chosen situations, we might use a lower prophylactic dose of anticoagulant temporarily instead of the full treatment dose until the absolute contraindication resolves. Then we can hopefully escalate back up.
Okay, that covers the absolute contraindications. Now, let's shift gears slightly within this initial stage. What about patients who present with really high-risk VTE, the ones needing immediate reperfusion therapy?
Right. This is a different level of acuity. We're talking about patients with hemodynamically unstable PE. Basically, they're in shock, blood pressure crashing because of the clot. Or those with massive iliofemoral DVT, sometimes called phlegmasia cerulea dolens, where the leg vein is so blocked it's actually threatening blood flow to the limb. Life or limb threatening situations.
So the really sickest patients.
Exactly. And in these cases, the standard approach often involves systemic thrombolytic therapy, the clot busters.
Giving powerful clot busters sounds like dialing the bleeding risk up to 11 to try and save the patient from the clot itself. What are the actual numbers on that risk?
That's precisely the trade-off you're making. And yes, the risk is substantial. Systemic thrombolysis comes with about a 9.9% incidence of major bleeding.
Wow, nearly 1 in 10 again.
Yeah. And the most feared complication, intracerebral hemorrhage or fatal bleeding, occurs in about 1.7% of cases.
That's still a scary number when you're talking about brain bleeds.
Absolutely. So given that level of risk, we really need a standardized way to decide who gets this therapy and who might be too high risk for it.
And that's where a specific tool comes in, right? The PECH score. Tell us about that.
Exactly. The PECH score is designed specifically for this situation, stratifying the risk of intracranial hemorrhage before you give thrombolysis for PE. It's based on 4 pretty straightforward prognostic factors. P is for peripheral vascular disease, that gets 1 point. E and A are for elderly, age 65 years, also 1 point. C is for prior cerebrovascular accident or stroke with a residual deficit, that's a big one, 5 points.
5 points just for a prior stroke with lasting effects. That's huge.
It really highlights the risk in those patients. And the last one, H or M, is for prior heart attack or myocardial infarction. That's 1 point.
So PECH, what do those scores actually mean in terms of risk?
The score gives you a direct estimate of the risk for that worst outcome, intracranial hemorrhage, if you proceed with thrombolysis. A patient with a PECH score of 0 has about a 1.2% risk of ICH. But as the score goes up, the risk climbs dramatically.
How dramatically? What about that 5-point score for prior CVA?
Well, if a patient scores 5 points, which, as you noted, could just be from that one factor, prior CVA with deficit, their estimated risk of ICH with thrombolysis jumps all the way up to 17.8%.
Nearly 18%. That's astronomical.
It is. It's a massive increase in the risk of a catastrophic bleed.
So while the score might not be perfectly predictive for every single person, its real value is in standardizing that incredibly high-stakes decision.
Absolutely. It gives us an objective way to quantify that risk and justifies looking at alternative strategies, maybe surgical removal of the clot or catheter-based treatments for patients who score very high on the PECH.
Right.
We need that objective measure before pulling the trigger on a therapy with such a high bleeding risk.
Okay, so we've navigated the immediate crisis, ruled out absolute contraindications, maybe even dealt with thrombolysis risk. The patient is stabilized. Now we move into stage 2. Upon discharge, this feels like where the longer-term strategy starts, particularly choosing the right drug.
Correct. This is where the focus shifts to ongoing management. And the big decision point here is definitely the choice of anticoagulant drug class. The landscape has really changed over the last decade or so. The standard of care now strongly favors the direct oral anticoagulants, the DOACs, over the older vitamin K antagonists or VKAs like warfarin.
And why is that? What's the evidence?
The evidence is overwhelming, really. Large phase 3 clinical trials involving tens of thousands of patients have consistently shown that DOACs are associated with a lower risk of major bleeding compared to warfarin.
Lower overall major bleeding.
Yes, and importantly, also a significantly lower risk of the most devastating bleeds, intracranial hemorrhage, and fatal bleeding. That improved safety profile is why DOACs are now the first-line treatment for most VTE patients.
Okay, so DOACs are generally safer regarding bleeding. Given that, why would anyone still use warfarin, a VKA, for VTE these days? Are there still situations where it's preferred?
There are a few specific scenarios. VKAs might still be considered if there are major concerns about patient compliance, perhaps because the long half-life is a bit more forgiving of a missed dose. Also, significant drug interactions can be an issue. If a patient is on other medications that strongly interact with DOAC metabolism, a VKA might be necessary. And of course, patients with certain types of mechanical heart valves still require warfarin, though that's less common in the typical VTE population.
You mentioned drug interactions with DOACs. Let's dig into that because that seems like a subtle but really important way bleeding risk could creep up. How do DOACs get processed, and what interactions should we be watching out for?
This is super important for safe prescribing. Unlike warfarin, which has complex metabolism, DOACs often rely on specific pathways. Key players are the CYP3A4 and CYP2J2 enzyme systems in the liver, and also a transporter protein called P-glycoprotein, or PGP.
Okay, CYP enzymes and PGP. Can you give us an analogy for how an interaction works there?
Sure. Think of P-glycoprotein, like a bouncer at the gut wall, actively pumping the DOAC molecule back out or into the bile for removal. And the CYP enzymes are like the main processing plant in the liver, breaking the drug down. Now, if a patient takes another drug that strongly inhibits PGP or CYP3A4, common examples include certain antifungal drugs like ketoconazole or some HIV protease inhibitors. It's like blocking the exit door and shutting down the processing plant at the same time.
So if the DOAC can't get out and can't get broken down efficiently.
Exactly. The drug just accumulates. Its levels in the blood spike much higher than intended.
And higher levels mean?
Higher anticoagulant effect, and therefore a significantly increased risk of bleeding. This is why it's absolutely crucial to check for these interactions. The drug labels often require dose reductions or sometimes avoiding the DOAC altogether when used with these potent inhibitors. It's a major safety check, especially early on.
Right, crucial diligence there. So once we've picked the drug and checked interactions, what's the next focus at discharge? You mentioned targeting modifiable risks.
Yes, and this is particularly important because, as we said earlier, those first 3 months have roughly double the bleeding incidence compared to long-term treatment. So identifying and fixing modifiable risks now is high yield.
What are we looking for specifically? What can we actually change?
The literature points to several key factors. Probably the biggest one is hypertension. High blood pressure, especially uncontrolled or severe hypertension, is strongly linked to bleeding, particularly devastating intracranial bleeds.
So getting blood pressure under control is key.
Absolutely. Aggressively managing hypertension seems very likely to mitigate bleeding risk. Second, we need to look at other medications the patient is taking. Minimizing, or if possible, stopping concurrent antiplatelet drugs like aspirin or clopidogrel and NSAIDs unless there's a compelling separate reason for them is vital.
Right. Avoid doubling up on blood thinners if you don't absolutely have to.
Precisely. Third, clinicians need to be alert for underlying causes of blood loss, maybe investigating for hidden GI issues, and counsel patients about moderating alcohol intake, as heavy use increases risk.
What about organ function? Kidneys, liver?
Yes, those are important too, especially looking for reversible problems. Renal function is particularly key because many DOACs are cleared by the kidneys. So a decline in kidney function, a drop in the estimated glomerular filtration rate, or eGFR, is associated with increased bleeding risk.
And the flip side.
And conversely, if you can identify and treat something causing temporary kidney impairment and improve their renal function, the evidence suggests you can actually decrease their bleeding risk.
Okay, this is all making sense. Fix the fixable things.
Yeah.
But here's something interesting from the sources that feels a bit counterintuitive. They say these modifiable factors, like the high blood pressure or the NSAID use, are actually relatively poor predictors of future major bleeding when compared to formal risk scores. Why is that? If they cause bleeding, shouldn't they predict it?
Yes, this is a fantastic point and a really important clinical insight. It seems paradoxical, right? The reason they're poor predictors and scoring models is precisely because they are modifiable. Think about it. A risk score is trying to predict the future based on a set of characteristics, many of which are fixed. But if we identify uncontrolled hypertension in a patient today, start aggressive treatment, and their blood pressure is perfectly normal a month later, well, that initial risk factor is now gone. The patient's risk profile has fundamentally changed because of our intervention.
So the prediction based on the initial state is no longer accurate because we intervened.
Exactly. And we have evidence, especially from big studies in atrial fibrillation where these factors are tracked closely, showing just that. Successfully treating hypertension or stopping an NSAI can lead to a permanent reclassification of that patient's bleeding risk down the line.
That's the aha moment then.
It really is. It tells us that the goal in stage 2 isn't just to calculate a score based on current modifiable factors, but to actively eliminate those factors. The change in the risk status over time, due to our interventions, becomes a much better predictor for that individual than a single baseline score could ever be. That's why applying a rigid score right at the start can be misleading.
That makes perfect sense. Focus on intervention, not just prediction, in this early high-risk phase. Okay, so the patient gets through those first crucial 3 months. We've hopefully managed the acute risks and tackled the modifiable factors. Now the whole conversation shifts again as we enter stage 3. After 3 months, the indefinite treatment decision.
Right. At this 3-month mark, the main clinical question usually flips. It's less about the immediate bleeding risk and more about the risk of the VTE coming back, recurrent VTE, if we were to stop the anticoagulant.
So we're weighing the clot coming back versus the bleeding risk of staying on treatment.
Exactly. We need to figure out if the initial VTE was provoked by something temporary, like that surgery in our earlier example, or if it was unprovoked, suggesting the patient might have an underlying tendency to clot and could benefit from longer treatment.
So in which situation does the bleeding risk assessment really come back to the forefront?
It becomes most critical for those patients who are at high risk of VTE recurrence, typically those with unprovoked VTE, who are now candidates for indefinite, potentially lifelong anticoagulation. For these patients, we have to carefully weigh their individual bleeding risk against their recurrence risk. This often involves shared decision-making, talking through the numbers and the patient's preferences. Sometimes, a high perceived bleeding risk is the deciding factor for stopping therapy, even if there's some recurrence risk.
Okay, so for that crucial long-term decision, potentially years or decades of treatment, we ideally need a really good tool to assess that bleeding risk. What makes an ideal bleeding risk score for this specific long-term scenario?
Yeah, for this indefinite treatment phase, the ideal score needs several key features. First, it has to be easy to use and repeatable. We can't rely on complicated or expensive lab tests every few months. It needs to use readily available clinical information.
Practicality is key.
Absolutely. Second, it needs to be relevant across the board for patients on VKDs and for patients on the different DOACs, since that's what most people are on now. Third, and this is really important, it must have been specifically validated in patients with unprovoked VTE during the chronic phase of treatment. That's the exact population and time frame we're interested in here.
Makes sense. And what was the fourth point you mentioned earlier about not predicting recurrence?
Right. This is crucial for clinical utility. The ideal bleeding score should not also strongly predict VTE recurrence.
Why not?
Because if a high score tells you the patient has both a high bleeding risk and a high recurrence risk, what do? Stopping the anticoagulant based on that score might prevent a bleed, but expose them to a potentially fatal recurrent clot. That's not helpful. The score needs to isolate the bleeding risk as much as possible.
Okay, so easy to use, relevant to current drugs, validated in the right population and phase, and doesn't predict recurrence. That's the wish list. How do the scores we actually have stack up against this? You mentioned limitations.
Yeah, that's where we hit some challenges. A major issue is that most of the older established scores were developed and validated primarily using patients treated with warfarin VKAs.
And DOACs have a lower bleeding risk overall.
Exactly. So the baseline risk is just different with DOACs, especially the factor Sa inhibitors. The absolute risk numbers generated by VKA-based scores might not accurately reflect the reality for a DOAC-treated patient. And frankly, if you look at the overall statistical performance, the predictive accuracy, often measured by something called the C statistic, it's often a bit underwhelming for most scores. They typically fall in the range of 0.5 to 0.6.
A C statistic of 0.5 is basically random chance, like flipping a coin. If they're statistically mediocre, why are we even using them? Should we just rely on gut feeling?
It's a fair question, and the statistics can look disappointing. But they still have clinical value, just maybe not in the way we'd ideally want. Even if the overall C statistic is modest, validation studies consistently show that patients classified into the high-risk category by these scores do have a significantly higher absolute rate of bleeding compared to those in the low-risk category.
So they can still separate groups, even if they can't pinpoint individuals perfectly.
Precisely. They're useful for stratification. They help us communicate risk levels to patients. your risk seems to be in this lower bracket, or you fall into a category where bleeding is more common. They provide a framework for discussion and can help affirm decisions, even if they aren't a magic bullet for prediction. We use them to guide, not dictate.
Okay, that makes sense. Let's get into the specifics of the main scores used for this long-term decision. Probably the most talked about for VTE specifically is the VTE-BLEED score. What's its story?
Right, VTE-BLEED is a strong contender. It came out of the RECOVER trials, which were pivotal studies for dabigatran, one of the DOAs. Its main strength is its focus. It was specifically designed and validated to predict major bleeding during stable anticoagulation, meaning after that initial high-risk 30-day period. So it targets the long-term phase we're discussing.
Was it only validated for dabigatran, or does it apply more broadly now?
That's the good news. Its predictive ability has been confirmed in studies using other DOACs, specifically the factor XA inhibitors, in trials like HOCUSI-IVT and the Exalia registry. In patients with unprovoked VTE on long-term treatment, being high risk on VTE-BLEED meant a 3 to 5-fold higher rate of major bleeding compared to being low risk. That's a clinically meaningful difference.
And importantly,
Importantly, it also predicts the really bad bleeds, fatal and intracranial ones. And crucially, it meets that fourth criterion we discussed. It does not significantly predict VTE recurrence.
it isolates the bleeding risk reasonably well.
Yes, which makes it one of the best tools we currently have for identifying those patients at genuinely low bleeding risk, which helps us feel more confident about recommending indefinite anticoagulation for them if their recurrence risk warrants it.
Okay, VTE-BLEED sounds useful for affirming safety in the low-risk group. What about the ACCP risk table? You mentioned it's more like a checklist.
That's a good way to put it. The ACCP table, which appeared in the 2016 guidelines, wasn't built using statistical modeling on patient data. Instead, the guideline panel reviewed the literature and identified 18 factors associated with bleeding risk. Because they didn't have the data to weigh each factor's importance, the classification is simple. If you have 0 risk factors, you're low risk. If you have 1, you're moderate risk. If you have 2 or more, you're high risk.
So just counting factors. How useful is that in practice?
Well, it was initially suggested as a way to flag patients in that high-risk 2 or more factors category for potentially stopping anticoagulation. External validation studies have generally confirmed that the risk does go up as the number of factors increases.
So it provides some stratification.
It does. It's quick, easy to apply, and gives a rough stratification. But its overall accuracy is still considered moderate, and it doesn't have the same rigorous derivation as VTE-BLEED. It's perhaps best used for quick checks and patient communication.
Got it. Then there's the RI8 bleeding score. Where does that fit?
The RI8 score came from the large international RI8 registry. It identified 6 independent predictors of bleeding. Its main limitation, similar to older scores, is that the RI8 registry primarily included patients treated with VKAs, warfarin. While it does show increasing risk across its categories, its predictive value for long-term bleeding on DOACs is considered modest. It also wasn't specifically tested in the unprovoked VTE population during chronic treatment.
Okay, so maybe less relevant for the specific question of indefinite DOAC therapy.
Potentially less tailored for that exact scenario, yes.
Finally, we can't ignore HAS-BLEED. It's everywhere in cardiology for atrial fibrillation. How does it perform when applied to VTE patients?
Right, HAS-BLEED is probably the most widely validated bleeding score in the world, but its validation is overwhelmingly in AF patients. To apply it to VTE, you have to make modifications. For instance, the original HAS-BLEED includes labile INR, which is specific to warfarin and irrelevant for DOACs, and conversely, it doesn't include cancer, which we know is a major driver of bleeding risk specifically in VTE patients, but less so in typical AF.
So after making those adjustments,
When adapted HAS-BLEED versions are applied to VTE cohorts, they consistently show that patients scoring low, often 0 or 1, do indeed have a very low rate of major bleeding. So, like VTE-BLEED, its main utility in VTE seems to be confirming safety at the low end of the risk spectrum. Most guidelines now suggest that for both AF and VTE, scores like HAS-BLEED are primarily tools to prompt us to look for and manage those modifiable risk factors, like uncontrolled hypertension, which is in the score, rather than being the sole reason to deny anticoagulation.
okay, so putting it all together for stage 3. It sounds like the current best practice is using scores like VTE-BLEED or perhaps ACCP, not necessarily to stop treatment in high-risk patients, but more to confirm the relative safety of continuing treatment indefinitely in those identified as low risk. Is that fair?
That's exactly the key message from the sources for stage 3. The evidence just isn't strong enough yet to say, your score is X, therefore you must stop treatment, especially if the recurrence risk is high. It's more about identifying the low-risk group where long-term therapy seems safest.
Which leads us logically into the final phase, stage 4, long-term follow-up and dynamic management. If someone is on indefinite anticoagulation, what does ongoing monitoring look like?
The key word, again, is dynamic. This isn't set it and forget it. For anyone on extended anticoagulation, regular check-ins are essential. You need to monitor adherence to the medication, check for any side effects or tolerance issues, and keep an eye on organ function, especially kidney function. Specifically for bleeding risk, you should be reassessing for any new modifiable risk factors at least once a year. Have they developed hypertension? Started an NSAID? And for those patients with known pre-existing risks that were hopefully managed earlier, like hypertension or borderline kidney function, you need to monitor those more frequently, maybe every 3 to 4 months, depending on how stable they are. We need to catch any deterioration early.
This stage is also where dose reduction often comes into play for long-term VTE prevention, right?
Absolutely. This is a common strategy, particularly for unprovoked VTE patients who have one or more persistent bleeding risk factors but still need ongoing protection. We often see reduced doses being used for secondary prevention, like apixaban 2.5 milligrams twice daily instead of 5 milligrams twice daily, or Varoxaban 10 milligrams once daily instead of 20 milligrams once daily. The idea is to shift that risk-benefit balance slightly more towards safety for the very long term.
Does that reduced dose definitely lead to less major bleeding compared to the standard dose used for initial treatment?
That's the million-dollar question, and the evidence is still evolving. Intuitively, a lower dose should mean less bleeding, and some studies support this. However, large head-to-head trials directly comparing major bleeding rates between standard dose secondary prevention and reduced dose secondary prevention are limited. It's a widely accepted clinical practice for long-term prevention, aiming to balance efficacy against bleeding over many years, but we should be careful not to overpromise the magnitude of the bleeding reduction compared to standard dosing used long-term.
Okay, understood. This brings us back to that concept of longitudinal assessment you mentioned. Instead of just one score, you're tracking changes. Can you elaborate on why that dynamic view is likely the future of prediction?
Yeah, this is where the field needs to go. Instead of relying solely on, say, the VTE-BLEED score calculated at month 3, imagine tracking that score, or the individual components of it, over years. For instance, if a patient was initially low risk, but then over 2 years they develop poorly controlled hypertension, their kidney function drops significantly, and they need to start aspirin for heart disease, their risk profile has dramatically changed.
The score itself would change.
Exactly. That change over time, the trajectory of their risk factors, is likely a far more powerful predictor of an impending bleed than any single snapshot measurement taken years earlier. It captures the reality that risk isn't static. We need to study how monitoring these changes predicts outcomes.
That dynamic perspective makes so much clinical sense. Let's try to make this even more concrete with a couple of case scenarios. Can you walk us through scenario 1? A 45-year-old man who develops a DVT 3 days after neurosurgery.
Okay, this is a classic high-wire act. He has a definite DVT needing treatment, but he just had transsphenoidal surgery near the brain. That's a major unmodifiable bleeding risk right there. And to make it more complex, he's also on low-dose aspirin for a previous heart issue. That's a modifiable risk factor we can address.
Starting anticoagulation just 3 days after neurosurgery sounds terrifying. How did they justify that?
It absolutely requires careful, individualized judgment. The team likely weighed the specific type of neurosurgery. Transsphenoidal can sometimes be less disruptive than other types, the perceived stability of the surgical site, and the severity of the DVT. They made a calculated decision that at day 3, the immediate VTE risk had just tipped the balance over the hemorrhage risk. They chose to start with low molecular weight heparin, LMWH, given twice daily. And importantly, the very first thing they did to mitigate bleeding was stop the aspirin, tackle the modifiable risk straight away.
Why LMWH initially, instead of jumping straight to a DOAC?
Good question. It likely comes down to control and flexibility in that very high-risk initial period. Many DOACs start with a higher loading dose phase. Starting that right after neurosurgery might feel too risky. LMWH has a shorter half-life, its effect wears off faster if you need to stop it, and the dose can be easily adjusted. It just offers more immediate control if bleeding does occur.
And did it? The scenario mentions a nosebleed.
Yes, despite the careful planning, he developed a minor nosebleed after 3 days. This shows how sensitive things are early on.
What was the response? Did they panic and stop everything?
No, it was a measured dynamic response. They immediately held the next scheduled dose of LMWH to let things stabilize. Then the dose after that was temporarily reduced to a prophylactic level, just to be cautious. But critically, they didn't abandon treatment. They restarted the full therapeutic LMWH dose just 24 hours later, monitored him closely, and thankfully, he had no further bleeding issues in the hospital.
Okay, good save. What happened at discharge and beyond?
Once stable for discharge, he was switched to an oral factor ZAZ inhibitor for convenience. But because his DVT was clearly provoked by that major temporary risk factor, the surgery, the plan was for a limited duration. Anticoagulation was stopped after the standard 3 months. And at that point, since the VTE risk was considered resolved but his cardiac risk remained, the aspirin was safely restarted for his long-term cardiovascular prevention.
That case perfectly illustrates managing conflicting risks, modifying factors, and dynamic response. Okay, let's look at scenario 2. A 41-year-old woman with an unprovoked low-risk PE.
Right, this is a different situation. She's younger, has an unprovoked PE, meaning higher recurrence risk, likely needs longer treatment, but it's classified as low-risk PE, potentially suitable for outpatient treatment. She comes in with known modifiable risks, hypertension that's not well controlled, and mild renal insufficiency, eGFR around 55 mmol/mL. She also has type 1 diabetes.
Okay, so long-term treatment is likely, but she has risk factors. Does her age and gender add another layer of complexity to the initial drug choice?
It absolutely does. Because it's a low-risk PE, starting treatment at home is an option, which makes the oral DOACs like apixaban or rivaroxaban appealing because they don't need initial LMWH injections. However, there's a known issue. Those direct factor ASIN inhibitors, apixaban or rivaroxaban, are associated with a significantly higher risk of causing or worsening heavy menstrual bleeding, menorrhagia, particularly in premenopausal women like her.
Oh, right. What about other DOAC options?
Well, dabigatran generally has a lower risk of causing menstrual bleeding, but it's not ideal with her borderline renal function, and it does require that initial bridging period with LMWH injections, making it less convenient for home start.
So, a tricky choice right off the bat. What did they do?
After discussing the pros and cons, they decided to start an oral factor ASA inhibitor, accepting the convenience but acknowledging the potential menstrual bleeding risk. But they didn't just start the drug and hope for the best. They immediately focused on her modifiable risks. At her first follow-up visit, just 1 week later, her blood pressure was still elevated, so they increased the dose of her calcium channel blocker right away. Stage 2 intervention.
Did the mental complication, the heavy bleeding, actually happen?
Unfortunately, yes. About 6 weeks into treatment, she developed significant menorrhagia, enough to cause new-onset anemia. This required another dynamic adjustment.
What was the change?
They decided to switch her anticoagulant. After rechecking and confirming her kidney function was stable, they transitioned her to dabigatran 150 milligrams twice daily, hoping to lessen the menstrual bleeding. Simultaneously, she received counseling and gynecological assessment, including discussing options like a progestogen-releasing IUD to manage the bleeding locally without having to stop the necessary anticoagulation.
That's great. Treating the side effect allows continuation of the essential VTE treatment. So fast forward to the 3-month mark. What was the long-term plan?
By 3 months, thankfully, the switch to dabigatran and the GYN interventions had worked. Her menstruation was back to normal, her blood pressure was well controlled on the adjusted beds, and her anemia had resolved. Her calculated VTE-BLEED score at that point was low risk, because her initial PE was unprovoked, and she expressed a clear preference for continuing treatment to minimize her recurrence risk. The decision was made for indefinite anticoagulation. But, and this is key, the plan included very regular follow-up, specifically mentioning checks 3 times a year for her diabetes control, blood pressure, kidney function, and overall health. This ensures ongoing dynamic monitoring of her risk profile.
These cases really bring the stages and the dynamic nature of this to life.
Yeah, they show it's rarely straightforward. If we try to connect all these details back to the bigger picture, what really emerges is that managing bleeding risk in VTE isn't about one single decision point. It's an ongoing process, a journey with the patient. It requires blending that clinical experience and judgment with the best available evidence from scores and trials. And maybe the most consistently impactful thing we can do across that whole journey is diligently look for and successfully reverse those modifiable risk factors whenever possible. That's often where the biggest gains in safety are made.
That's a fantastic summary. It really highlights that distinction between just predicting risk versus actively intervening to change it. And it reinforces the idea that the risk scores we have now, like VTE-BLEED or ACCP are probably best used not as absolute cutoffs to deny needed long-term therapy, but more as tools to help confirm the relative safety in lower-risk patients and as frameworks to guide that crucial ongoing dynamic monitoring over time.
Precisely. And maybe that leaves us with a final thought for you, the listener, to ponder. Where does this field need to go next?
The real next step, the holy grail perhaps, is developing and validating integrated prediction models. Models that don't just estimate the risk of bleeding or the risk of recurrence separately, but actually combine them. But integration means more than just adding the percentages. It has to weigh the impact or the severity of each potential event. What's the case fatality rate of a major bleed versus a recurrent PE in this specific patient? What's the long-term disability or impact on quality of life for survivors of each event? When our models can truly integrate not just the risks, but the consequences of those risks, that's when we'll be able to calculate a much more meaningful net clinical benefit and truly personalize VTE treatment duration decisions. That's the future we should be working towards.